Okay, shall we begin? Welcome everybody to the Merton CCG governing body. Just as a reminder, we're being recorded, so can everyone, if they're speaking, remember to use their microphones. And we are not expecting a fire alarm test today, so if the fire alarm sounds, we'll need to leave via the emergency exits. There's one at the back there, or through those doors on our left. We've got a number of apologies which I'll go through, but despite that we are still quorate. But we've got apologies from Josh Potter, Karen Worthington, Mike Greenberg, Andrew Lee, James Murray, David Smith and Sam Page. Alison Roberts is standing in for Josh. So, any declarations of interest that I need to be made aware of? We've got the register, is that accurate? Can people confirm that?
Just to add all the networks, the PCN networks will need updating for... Sorry, the PCN networks probably need to be recorded as well now as of the 1st of July, so, which is with the ACDs for Northwest Merton, PCN.
I'm not an accountable director, but I'm a member of East Merton PCN. Yeah.
So all GPs who are members of member practices, which is all the GPs, their practices are now members of primary care networks. But you've got a specific role, Tim, because you are the accountable clinical director for your primary care network, and Andrew, you're the chair of your primary care network.
Yeah, I've been told that they're not going to be boards, so it won't be a chair, but convener or whatever of that network. Yeah.
Okay. And Marek, did you have something?
So just one comment to make about that is that issue was raised at the Clinical Quality Review Group as a matter of potential conflict, and that if a number of GPs are potentially conflicted, that might affect quoracy. So if issues arise around PCNs that may require somebody to recuse themselves from the discussion, it needs to be highlighted well in advance of the meeting so that appropriate measures can be taken to ensure quoracy.
Sure.
Yeah, I mean, I think I'd agree with that. I think we need to be, as you say, cognizant of what's on the agenda. I think that the conflict only becomes a specific and direct one in case of us considering business that directly relates to PCNs on this agenda. But it is worth us continuing to be mindful of it, and we have provisions for primary care committee which, if necessary, we'd have to replicate it.
Good. Okay. Can we go to the minutes of the last meeting that was held on 1st of May then, just to confirm that we are happy with those? So let's quickly go through them page by page. Page 1, which is page 9 of your pack. Page 2, third page, page 4, page 5, page 6, page 7, page 8. So are we happy that they're accurate? Yep. Okay. I haven't been notified of any matters arising that aren't on the agenda. Correct me if I'm wrong. No? Okay. Good. Well, we'll go straight on then to section 3. So the first thing is the chair's update. These are all verbal, the chair's and accountable officer updates. The two things I really wanted to flag up was firstly that our primary care networks formally went live on the 1st of July, and it's very pleasing that in Merton we've managed to agree that, and all practices are happy as part of one of their 6 primary care networks, so that's a real success. I think that builds on the work we've done previously in starting to get practices to work together in their integrated locality teams, so it wasn't a big leap for us in Merton to form the primary care networks, and I think that's a real positive. The second thing to say is that a number of us from South West London went to the NHS Confederation, and I think we learnt quite a bit there. The thing that stood out most for me was the talk we had on race, and there was a real challenge to us as a South West London system, as a CCG, to take seriously the issue of workforce race equality standard, and not just looking at that as a tick box, but really starting to make progress on that. What we did agree when we were away is that Michelle Rahman from Sutton is going to take a lead for us looking at that at South West London, which I think is really positive, and I think it will give us an opportunity to really start to make progress on that in a much deeper way. And I've certainly said that I'd support her with that work going forward. In terms of managing director, James, one thing you want to say?
So most of my the normal contents of my update are covered elsewhere on the agenda, so that's why I haven't submitted a written one today. In particular, we're talking about the BAF, we're talking about moving forward together. Just one thing that I will say is I attended an all-day meeting of the Merton Partnership Executive Board a couple of weeks ago. This is where leaders of all the public sector organisations in Merton come together to discuss key things that affect us all, and we had a focus on building social capital in Merton. So this is basically about building the resilience of communities and strength within communities in the context of everything that we deliver across public services, and we've committed to doing a number of things to help build social capital, and this is really about looking for ways within our existing strategies to continue to work on social capital goals. So a really good example is about how we support building capacity within the voluntary sector as part of our social prescribing initiatives, about how we use the opportunities around the redevelopment of the Wilson to provide facilities for voluntary sector organisations and for community, for more informal community groups as well, which is something that we're looking to do ahead of the formal redevelopment using the current estate. So just really helpful, and I think probably quite helpful in the context of the health and wellbeing strategy item that we're going to have later. And I'd say, you know, it was actually my first time attending it, and it struck me of how effective a cross-public sector partnership we have in Merton. I think it's something that that actually other areas could take some learning from, so that's really good.
Thank you, James. Sarah?
So mine was just to update everyone that the guidance on the new long-term plan is now out, and across South West London we'll be looking at developing a plan for South West London, because it is a South West London level plan that we need to produce. And there's a 44-page document. If you haven't read it, I would recommend that you do. I have, and there's a lot of information in there, and there's a lot of work for us to do in order to get to a draft plan by the end of September. We're hoping that that will be signed off by governing bodies at September meetings, and then there will be a final plan sometime in November, which will then be published to the public. So we've got a lot of work to do, but I would say that the work that we're already doing will feed into that plan. So the work that we do on local health and care plans, the work that we've already identified across South West London through the Clinical Senate, and the work that we do around the enablers will be part of the South West London plan. So there won't be a new plan, it will be how we bring that together into something that we then need to put forward to the regulators.
Thank you, Sarah. Any questions on any of those items? No? Okay, I will move us straight on then to the Merton Health and Wellbeing Strategy. Dagmar, you're going to take us through that, are you?
Yes. Thank you, and apologies for being a bit late. Guess what? I had a flat tire. I don't know whether that counts for anything, but I say it anyway. So many thanks for giving me the opportunity to share with you the final Health and Wellbeing Board strategy draft. And just as a little bit of context, the Health and Wellbeing Board strategy is a statutory duty. And when I talk you through, I think it's really important to sort of give credit that the board tried to apply learning from its previous strategy to really think about how they can add most value. So if you bear with me, what you are asked in a way to do, because obviously the CCG is a partner, a very important lead partner of the Health and Wellbeing Board. Andrew is the Vice Chair, and the Health and Wellbeing Board has already approved the strategy, but I would like you really to not only note it, but champion it. And you will understand a bit better what I mean I will give you a very brief sort of potted version, so don't worry that I will go page by page. But the first important thing is that what is the Health and Wellbeing Board actually meant to do, and as a statutory partnership, so it's only a partnership, nobody is the boss and it hasn't got money, so it works through influencing, but it has as its duty the oversight and strategic sort of system leadership for health and well-being. Now that's a really big thing. And if you think about it, it could easily degrade into, in terms of a strategy, putting everything and anything laudable into a nice and glossy document. And as you can imagine, I've looked up and down the country at some strategies, that's what you do, and a number succumb to that temptation, because there is just so much that you could do. But we as a board said that is not going to wash. And the first thing we've actually said is, so our duty spans the whole of health and well-being. And if you think about it, and I don't need to tell you, that a really important part are health and care services. But another really, really important part is what we sort of snappily labeled healthy place. What we mean are the social and physical conditions. And we very quickly said, who is best placed to focus on what? And so we have agreed as a Health and Wellbeing Board, looking around the table, what is our strength and what are our main levers? And we've said, let's really focus on healthy place. As a wraparound to the local health and care plan that looks at the service provision that is led by our Merton Health and Care Partnership, because who there is around the table are also our providers of health and care services. So that was quite an explicit decision. It doesn't mean that the Health and Wellbeing Board is abdicating its responsibility to look at the whole, but it was a real explicit decision to think as system leaders who can do what best. And for me, there's real learning for the ICS as well, because if everybody tries to do everything, we're not really mobilizing in the best way. So the little diagram, number 2 on your page 148, hopefully gives you a little bit of a feeling that you've heard Josh coming, I think it was the last meeting, to present the local health and care plan, and you will hopefully recognize how, like fingers in a glove, these two really hang together, with a healthy place being the wraparound, the conditions for health and care services. Then we did a little bit of thinking around what could actually go into the strategy, and we wanted the strategy to be a tool, almost like a compass that the partners can use in all their business. And so if you look at page, sorry, which page number is here? Yeah. So it's your number, page 23. So some of the learning that we pull together, how the board actually adds value, is one thing is that it can champion some principles and ways of working. And it means what it says. It's not just, having some principles and ways of working and then doing business as usual. So the request, and almost what I want this board to do, is actually saying, yes, we are going to stand up for these. And then to have a strategy as a tool that focuses mainly on outcomes. And the way we've structured them is so that they fit with the local health and care plan into start well, live well, age well, and with a particular focus on healthy place. And we've done quite a lot of work with stakeholders to crystallize what people mean by healthy place. And then the way we do the delivery, because lots of people came to me and said, you know, I have to go to scrutiny, etc. Said, where's your delivery plan? And again, the board has quite explicitly said this is a 5-year strategy. To nail us down over 5 years to deliver is unrealistic. We have to be more nimble and agile. And so we are committing to an annual rolling program of a few priorities where we definitely then have a clear delivery plan, but that allows us to adapt and jump on opportunities as we go along. So we will propose the first priorities in a paper in October, and I can let you know a bit. So that's roughly the learning. We have done wide engagement, and what we've tried to do is really engage the members of the Health and Wellbeing Board. They have led workshops, so that it's not an officer strategy that members then sign off. It's their strategy. And for me, it was really important. We've worked over the last 8 months on this, that the process of developing this strategy is a system leadership intervention. Because I'm now watching people, how they talk about health and healthy place, and I see it rubbing off, and that is a part of the purpose of the strategy. So if I very quickly move you on, what do we want to achieve? Because that is the skeleton, the bones of this strategy. There are 6 principles and ways of working, and I want to go quickly through them. They won't surprise you, but if you think about them deeply and think, God, can we stand up for them? I think we've done a lot of work to whittle down what really matters. So the number one that really sort of fires up the Health and Wellbeing Board in terms of values and purpose is fairness. So tackling health inequalities is one of our guiding principles, and that's, for example, why the Health and Wellbeing Board is the sort of sponsor guardian of the Wilson project. We are very committed to prevention and early intervention. Now that requires leadership in times of austerity, because the prevention services are the first to go. A health and all policy approach, really important. It means that we are actively looking at maximizing the positive impacts and mitigating the challenging or mitigating negative impacts. Community engagement and empowerment, with a particular emphasis on looking at assets and strengths, so not doing to people, but with people. And I think the engagement that sits behind that strategy sort of gives an example. Then very importantly, and I have a sort of bee in my bonnet, it's experimenting and learning, because the problems we are facing are really complex. There aren't any silver bullets. Sometimes we dream of them, but forget it, that's just selling snake oil. It's not, there aren't any silver bullets. So we have to try out, we have to have a plausible idea, and then we have to try out and learn, and I think we can strengthen that. We're not always the best in really tying the loop and doing the learning. And then finally, and Rachel was very outspoken about it, that specifically the Think Family theme, to make it one of our principles and ways of working. So taking a whole family approach, that means whenever you see parents, you think the child or children, and whenever you see children, you think about the parents. And if you think that through, even as a practitioner, it's not hardwired. We have got really good examples, but hardwired, that's what we wanted to become. And what we've tried to do, and Andrew was very instrumental as well to push it, so we have put in the appendix a sort of table that shows how we think we can actually measure and monitor some of the impact of living up to these principles and ways of working, so that we have some idea of progress. And I'm almost thinking like to use them a bit as a yellow card if we think something is really going adrift, that we can remind each other as well that we have committed. In terms of key outcomes, we have done a lot of work around asking people, well, what is this healthy place? What are some key attributes that really matter? And it was interesting across Start Well, Live Well, Age Well to have a lot of consistency. So 3, and because I'm a simpleton, so I can't hold very many more, we could whittle down. One is promotion of emotional and mental well-being. So really, really important right across the ages. Then a healthy place is a place that makes the healthy lifestyle choice easy. And it's the old culprits around food, physical activity, tobacco and alcohol. And then very importantly, the third one is protecting from harm, providing safety with a particular focus on violence and air pollution. So these 3, I think we all can sort of almost remember, and we've then put outcomes across them. And just as an example, I won't go through the whole table, but how it is experienced slightly differently across the life stages. So for promoting emotional and mental well-being, the issues particularly prevalent for children and young people was on one hand self-harm, and we're already doing a lot of work, and you have heard us speaking about it. And then the sort of the positive flip side was that they were talking about relationships amongst each other, peer relationships, and very, very importantly, trusted relationships with adults. In the Middle Ages working population, it was stress. It was very high on the agenda. It had often something to do with a double caring responsibility of children, work, and possibly grandparents, all in one go. And then in the older population, it was particularly loneliness, and therefore the flip side, then the positive, is how can we connect and how can we continue to contribute. Now, this is clearly the outcomes. We have chosen some marker outcomes. It's not the whole list. We could measure all sorts of other things, but it gives you a flare of the bones of this strategy. And then the third part was that we spoke to people how they experience healthy place. And the way people live their lives is in settings. And settings are a very helpful way of delivering healthy places. And again, across the life course, some of the most important settings are listed in the table. And again, in terms of accountability, the good thing is that settings can be measured, whether they are healthy settings or not, and there are acknowledged standards. And just to let you know that one of the priorities for our rolling program, we will discuss it in October, but the suggestion is that we really focus on healthy workplace as a setting, and we have the standards, etc. So I will leave it there. It hopefully gives you an understanding of the bones and meat of that strategy, and I'm happy to answer any questions.
Thank you very much, Dagmar. As I said, because we saw this at the Health and Wellbeing Board recently, I think it's really helpful that this complements the local health and care plan. They fit well together. It's not a duplication, actually, it's additive, and I think that's really good. And I think the priorities that are set out in here reflect a lot of the work we've done together as a Health and Wellbeing Board over the years, so I think that's really positive. Shall I open it up to questions or comments from members of the board? Claire.
I just wanted to say that I've seen lots of strategies by health and wellbeing boards over my life, and this sings. It absolutely sings. It's so straightforward and simple and direct and clear. So well done, everyone who's been involved in it. It's really accessible. The engagement that has been done is fantastic. Again, well done. I really loved the phrase, be brave and take risks. I think that is the watch phrase in this document, so thank you.
I agree. I think it's very good, and I think there's a sense of connection to the communities within the borough, within it, that comes through, in that it's realistic about the lives that people have, and it's realistic about how you talk to people about the lives that they have and the lives that they would like to have, and to support them to be more healthy. I think the question for me probably is about how we embed improvement against these outcomes now into everything that we're doing through Merton Health and Care Together, through the local health and care plan, about how when we're thinking about setting our plans for next year, when we're thinking about areas that we want to take forward transformation work, when we're thinking about how we run our organisation, what are the three things that you would say? Always go back to these things, 1, 2, 3, and see if you can embed them in just about everything you're doing from a CCG perspective.
Well, boil it down even more. So the idea was, and I think again Andrew suggested it in the discussion we had in the Health and Wellbeing Board, absolutely, how do we keep this alive as a compass? And I think the principles are the principles, and I think they could maybe easily, or whatever, laminated, plus the bone, so the three attributes of a healthy place. And what we've also agreed is that we've already given you in the appendix the table with some marker outcomes. So we're doing a bit more work so that we are all agreeing on the baseline, where are we all at the moment, and then what are realistic monitoring frameworks for the different outcomes, where we can be realistic and honest with ourselves what direction we are moving. But I think, and James, you were there at the Merton partnership, and what struck me there was we talked quite a bit about marginal gains. And there are obviously, if you think about how change happens, and I'm, as a scientist, quite intrigued to observe nature. Yes, you have the odd volcano, and then the whole landscape is changed. But actually, most of it is adaptive change. Small steps with feedback loops. That is how there is constant change and adaptation. And the principle and the idea of the marginal gain is that if we all apply our even small effort on the same thing, we get somewhere. And therefore we discussed quite a bit in the Merton Partnership how important our own leadership is. People, our teams, our partners, look, how do we actually behave, and do we live up to what we say? And I was intrigued looking at David Sloman's principles of leadership that he's just shared with London. There was something as well about that consistency in our own little world. I think apart from some transformational sort of volcano stuff that we're doing in Southwest London, not to underestimate the importance of the small steps. And those I think we can do on a daily basis in every meeting, in every interaction we do.
Right. No other questions or comments, I think. You were bringing this so that we're cited on it, so we feel we own it. I think from the feedback you've had, it's been quite warmly received, so well done. Thank you, Dagmar. Shall we go on then to section 5, strategy and planning. The first thing is the 360-degree stakeholder survey, and Jen Nolan is going to come and talk about that. Jen, do you want to introduce yourself, and then I'll hand over to you.
Thanks. So I'm Jen Nolan. I'm the Head of Communications for Merton CCG. And what I'm presenting today, which is within the pack, is the results of the annual national survey that's carried out by Ipsos Mori on behalf of NHS England. So this is a survey that's sent to our stakeholders. Responses are anonymised, and I think it's important to note that the questions are quite different than last year, so it's not possible for a like-for-like comparison on these questions. But I'll just go in and pick out some of the key bits, I think, from here. So I'm sure you'll agree the responses are very positive. I think Merton's is certainly one of the best across South West London, and nationally it's very, very positive. And especially, compared with other South West London CCGs, and I think it really demonstrates strong stakeholder relationships, and that's really quite notable with member practices, local authority respondents, which I should note are included in the wider stakeholder group due to an error in how the response was sort of accumulated by Ipsos Mori, but the local authority respondents are included within the wider stakeholder group, so that should be noted. And just to note that 94% of respondents said they had an effective working relationship with the CCG, and the response rate was 70%, which I think you'll agree are both very good. There aren't many negatives really to draw out of this, but I have had a look through, because obviously we want to take whatever learnings we can. So I've drawn out the response which had the most negative responses. It was still only 7 out of a total of 33. So 80% still responded positively to this question, but it was around reducing health inequalities. So in terms of the next steps I'm asking the board to note and really say that they're happy with are around, we received quite a lot of verbatim comments, which we always do. There's a lot of them, and we sort through them and try and theme them. They're not published today, but we are suggesting the ones specifically relating to primary care engagement are discussed at locality meetings, and we'll also look at how we work to proactively publicise work that's happening to reduce health inequalities. So I think that's really important in response to that question. And we'll also take steps to drive up the response rate next year. So although 70% is still good, we think we can do more to make sure we're flagging to our stakeholders it's been issued to, that this is coming from Ipsos Mori, and encourage them to respond.
Thank you, Jen. Sarah.
So I just wanted to congratulate Merton CCG on the fantastic results. What I would say is last year I think was most improved CCG in the country on stakeholder survey. I think I'm right in that. And we were worried. We thought, oh, can we keep this up? Is this, are we going to go back down? And actually this shows, you can't do a direct comparison because they're different questions, so it's quite difficult to do a direct comparison. But what this shows is that it's still improving, or at least in a good place for Merton, and I think it's really, really positive. So, and well done to all the people, because this is about people getting out there and talking to our partners and stakeholders, and and them feeling listened to. So, really good.
Andrew.
Hi, thank you. I think it's really positive, and I guess the one thing that we would love to see that we maintain as we go forward with the very likely probable change in South West London and the structures is, I think, a large part of this is down to the great management that we've had within the CCG as being part of the LDU, and it's just trying to make sure that we maintain and retain those individuals, I think, that have helped make a difference to what we provide as a borough, but is backed up by the LDU.
Yeah, I think that's a really important point. Claire.
I just wanted to know, how are the groups chosen, particularly the voluntary and patient groups? How are they chosen, and who chooses them?
So as a CCG, although the responses are anonymised, we select a list of our stakeholders, and so we had a broad representation across voluntary sector and community groups, and I can check who it was sent to for you and share that.
I just wanted to respond as well to the one negative, so the perception that there's possibly not enough emphasis on reducing inequalities, and you can never do enough, but I think it is also the perception out there, what's happening and not. And I think, Sarah, the long-term plan and now the implementation plan for the long-term plan, reduction of inequality is deeply in there. So it will help us, I think, as well, to be really accountable for our contribution to inequality reduction.
Yeah, and I think it was quite timely that you just presented the health and wellbeing strategy, where the number one priority was reducing health inequalities. So it's not that there isn't a commitment to that, we've just got to make some progress on it.
I think what I would say around that is that we, over the last 2 years, I think we've definitely taken a very explicit approach of thinking through inequalities issues in terms of, where we do things first, where we commit some management time to sort of tackling issues. And I think that absolutely, when I think of where my team are focused in terms of addressing issues of service development and transformation, resilience of services, then I think that there is a shift now towards ensuring that, there is an active focus on health inequalities. I think that there is, what stakeholders will expect to see is some real results from that. And I think that we need to be able to talk about those results, because sometimes those results are about sustaining services and having resilient services to support those communities, and sometimes it's not the glamorous transformation stuff we do, it's actually the keeping stuff going stuff that we do. So I think we need to be able to talk openly about that at times, so that people do understand that side of our work, as well as the local health and care plan, which is about positive and developmental things.
It was sort of building on that, really. I think I had a look into the comments that were made around that point in particular, and there were a couple of comments that suggested the CCG does consider health inequalities when it comes to east and west of the borough, but perhaps doesn't always look more deeply than that. And I was thinking, actually, with the advent of PCNs, actually we have a real opportunity to bring those other areas of the borough much more to the forefront of our conversations around transformation as well. So it's making sure that the directors for those areas are having the opportunity to feed in as well.
Thank you. Okay. Well, we were asked to note that and to look at the next steps, which I think is really helpful. So thank you very much, Jen. I think it was really positive, and well done to everyone for contributing to that. Right, let's go on then to 5.2, which is the board assurance framework.
Shall I go? So this is brought today as part of the 6-monthly cycle that we bring the BAF to the governing body. Just to re-emphasise what it is that you're getting and the purpose of it. This is an assurance tool that uses principal risks to the achievement of specific objectives as a means of assessing or taking confidence as to sort of where we are in terms of our ability to achieve those particular objectives. So it brings forward specific risks from the corporate risk register, and then it maps sort of controls and assurances that we have in place for each of those specific risks, so that you can see what we're doing to mitigate some of the things that might impact on whether we are actually able to do what we set out to do as a CCG. Just on the back of that then, just to clarify what the basis is for what brings the risks forward and what classifies them as principal risks. They are risks that have an inherent risk score of 15 or above on our risk matrix. And then you have at the minute 5 that fit into that criteria that we've brought forward here for you to see. What you will notice is that, and which is a positive thing that you'll see from this, is that the residual risk scores have been significantly reduced on most of them as a result of the actions that we've taken to manage those particular risks. So that can be taken as an element of confidence that we have systems in place to manage some of these key areas. So the paper is really here for you to obviously discuss and to agree that you're comfortable in terms of what's presented here. If there's anything that you felt was missing or should be presented differently. Just to point out 2 things that I did notice just before we start talking, that what is usually automated on the residual risk score and the summary hasn't picked up the fact that the top 3 risks should actually be amber because they have been mitigated down. So they're not red. There's a big clump of red risks there, but they're not actually currently red. And also, one thing with risk 2.6, it hasn't actually increased as we've tried to put actions in place. It should actually say 5 by 4 and 20 as the inherent risk score. But you can see that on page 87 where each of the individual risks are listed separately. So happy to move to any questions that anybody's got on those.
Katie, did you want to come in?
Yeah, I just wanted to call out one issue that I actually need to pick up specifically. So objective 2, there's a risk 79 is around capacity and capability available to manage more complex patients in primary care. The actions and controls that have been pulled through relate to Wandsworth. Yeah, I think this is because it's been rebadged as an LDU risk. This is something that is a risk in Merton, and we do acknowledge that as well. In terms of some of the things that we're doing around that, so we have our integrated locality teams in place, which we've actually expanded this year. We have a number of local PMS KPIs that relate to this as well, and things like our social prescribing programme as well, very much acknowledging that complex patients don't just have medical needs, they have social needs as well that need to be addressed, are probably the sorts of things that we need to list in here. So I just wanted to call that out for the governing body.
Thank you. Neil?
Yeah, just to flag on, so putting aside the fact the front sheet, which Fraser has said it was incorrect, but on the on page 87, what I've done is wrap all the finance risks together into one risk, where I think previously we had the financial risk sitting in over a number of risks. So basically they're all now under one with the cause and effect, then all the individual risks that sit under there. So it should be a bit easier to understand that.
I think from my perspective this is neater and clearer than we've seen previously, which is helpful because it does focus you in on what the really important things are. The question for the governing body, I think, is there anything that we're missing? So are there any really important risks that we've not got captured? And also...
So one thing I want to make clear that this is not all of the risks for the CCG, so this is just, so it just pulls through the small number of principal risks.
The really important ones, yeah.
Yeah.
And also, I'm assuming you want to know that we're assured around the mitigations that have been put in place, so the controls.
Yeah, yeah. And so another thing that I can add there is that recently we were audited by our internal auditors, and specifically around the whole process, not just this document, but the whole process that sits behind it, so how we actually manage and review risk. And we were given pretty much a clean bill of health, a green rating. So you can take some assurance from the fact that that independent review has been positive as well.
Claire?
Can I just check with objective 5, the target date for mitigation is, objective 5 is the primary care workforce pressures in PMS. It seemed quite a long way forward, the 27th of March 2020. Just wanted to check what the thinking was behind that.
So I actually think it's quite a short deadline to address workforce pressures in primary care. I think that one probably went in as a result of we've got actions that we're currently putting in place this year that will be fully in place and established by March 2020. However, I think there will then be an ongoing series of other things that we need to do that go way beyond that date as well to make sure that this risk really is managed properly.
So the target date should be the date at which you think you can fully implement the controls that lead to your mitigated risk score. I think Katie's right in that one. I think it will be an ongoing risk for a much longer period of time. But it feels like the right date. If you look at those 4 controls on the left-hand side, they feel like they should be sort of fully in place. And we should be able to assure that they're working by that day.
And can I ask a question, follow-on question from that? Does the primary care strategy now reflect the new workforce coming through the PCN contract? Because clearly one of the mitigations for this now is your clinical pharmacists and social prescribers and all the other roles lined up. And I know we're putting some thought into how we support practice, making sure that we've got that pipeline of people coming in.
So our local Merton primary care strategy we did update in March, so it reflects some of that. I don't think it's perhaps as forward-thinking considering what the longer-term ambitions in the GP framework are. we probably need to be looking at that again. But we also have a South West London strategy that I think we're just in the process of finalising now. We had to submit that to NHS England, I believe, at the end of June. So that encapsulates a lot of that work as well, and I think it's probably about making sure that we don't in future have a local strategy and a South West London one, but making sure that they're aligned.
Okay. I mean, the other thing that I'm aware of in terms of workforce pressure on primary care is the issue of practice nursing, and there are real issues about getting the numbers and calibre of people into those roles. I had a meeting with the Director of Strategy from CLCH where I think we both agreed that was probably a priority for Merton. So I guess my question would be, where are we at in thinking about nursing, not just in primary care itself, but community nursing and how we make sure we've got the right workforce across?
So in terms of primary care itself, Fiona White is leading on a number of pieces of work looking at that, putting in place the 10-point plan that's within the not the RCGP, the RCN framework that's come out. In terms of joining things up with other provider organisations, I suppose, in the borough, I've actually had an email exchange this morning between ourselves and the team who are leading this element of the Merton Health and Care Together plan. So we're going to be meeting with Dagmar, Rachel Wardell, Merton Health and also our local CPN leads to talk about exactly how we can be a bit more proactive and forward thinking with those things.
Just following on from that, so I attend the meeting that Fiona White does, which is across South West London. There's a lot of work going on around training and education, and just at the last meeting we were discussing doing that joint training with CLCH so that we could have both practice nurses, practice staff, as well as the community staff as well in the same room doing that training. And buddying up where we can so that we can fertilise the skills for community and general practice. So there's quite a lot of work going on, and it is done across South West London. We have representations from each of the senior nurse leads from primary care at those meetings.
So just this morning I was at a Cross Wandsworth Public Sector Forum convened by the leader of Wandsworth Council, and we had a conversation about workforce pipeline, and the major further education provider in Wandsworth and Merton is the same at South Thames College, and there's certainly areas where they can support us, but perhaps possibly not around nursing from an FE perspective, but from Roehampton University is a major nursing trainer, and they are very keen to work more closely with local NHS provision around placement arrangements. And I think although they were highlighting mental health nursing, which is another deficit area, actually it did occur to me that one of the problems with practice nursing is that it's not necessarily something that people choose to go in first. It doesn't possibly sometimes have the visibility and profile of hospital nursing, but I do wonder whether working with an education provider we could start to shift that, because actually I think that there are complexities and challenges in practice nursing that would be quite attractive to some people coming into the nursing workforce now.
So Roehampton are starting a new course in September, which is for practice nurses. So for where generally you have a nurse training, they spend the majority of the time in an acute hospital. They've set up a course where they'll spend the majority of the time in general practice. So they're looking for placements in the local area. I think one of the areas that we struggle with is practices taking a student nurse when there's a lot of work and effort needs to be put in for very little gain at the time. They get something like a very minimum amount a week to take that person, but it doesn't cover backfill or anything. So there is a lot of that's been developed. One of the things we don't have, and we're looking into, because there's a model in South West London, South East London where they do, is a placement team that looks at placements across the whole of South West London. At the moment, the universities go to each of the nurse leads to see if they can place them in their practices, and there's a very good model apparently in South East where they do have a team that look at that. So we're linking up with someone there to see if we can do that and try and coordinate it a bit better. But I think we'll still have the challenge of getting the nurses into general practice. We've got a lot of sign-off mentors now and nurse mentors in primary care, more than we've got students going into primary care. But Roehampton will definitely help. They've developed that with the South West London nurses to particularly focus on nursing in primary care.
That placement team sounds like a brilliant idea, and I just wonder if the CEPN could help us maybe with it. Yeah.
And it is the CEPNs that get together that discuss that, so it is being looked at.
Yeah, I just want to add, so I was at the CPEN, now called Training Hub, meeting yesterday, and there was a real discussion about, we look at portfolio GPs and actually looking at portfolio nurses, and actually can they do a cross-role in hospitals and in community, and that heavily featured CLCH's role in terms of their academy they're building up. Also looking at the HCAs in terms of upskilling them and sort of seeing whether they can sort of move into the nursing skill mix as well, so certainly discussions around that.
Good. Anything else? Are we happy then with the board assurance framework? Yes? Okay, thank you. Yeah, it was. I think that's the point of it. Isn't that the point of a board assurance framework? You pick up the areas where you want some more assurance. So let's go on to 5.3, which is the new CDOP arrangements. Julie.
So what you've got in front of you is a paper that informs you of the new changes that need to take place in regards to CDOP procedures across the country, really. We have arrangements in place in all of our boroughs at the moment that look that manage the CDOP arrangements, and that came from the Children's Act in 2004, where there was a requirement for local authorities to take the lead on these arrangements. In the Children and Social Work Act 2017, when they Working Together to Safeguard Children, they set out some reforms to the existing arrangements, which means that there's a shift in responsibility now of the ownership of the CDOP arrangements. So where the local safeguarding boards used to manage that with the local authorities, they're now the responsibility shifts to what's called the Child Death Review Partners, which are the CCG and the local authority. So the reason that was done was because it was felt that there was a large variation in the local governance arrangements and limited standardisation across CDOP processes in many different areas. And that led to inconsistency, particularly around data collection, but also around learning and being able to share that learning in a wider footprint than just that one local area, which would have been the local borough. So what we need to do is increase the geographical footprint of the child death overview procedures, which is the CDOP meetings that we have. So currently we do have them in each borough, that's what the arrangements are at the moment. And the guidance says that we should be looking at a number of reviews of around 60 as a minimum, so 60 child deaths, so that you can look then at what the themes are and what the learning may be across a wider footprint. So in South West London, we have about 100 a year in the whole of South West London. So that fits within the guidance and the footprint that we need to look at. So the proposal is, and it's not really something we've got a choice about, but the proposal is that we have a CDOP arrangement across South West London rather than 6 individual CDOP discussions taking place in the local area. One of the other things that we need to look at is the data collection that takes place around any child death, and as I said earlier, there's an inconsistency around that, and there's going to be a system, National Child Mortality Database, that's going to be in place, which is a live database that when anything happens, a child death happens, it's immediately put onto that system so that that can be looked at nationally to see if there's any themes and immediate concerns, but issues that are nationwide that can be addressed on a wider scale. In South West London, we do use a system called electronic CDOP, where we do update an electronic system that does filter into the National Child Mortality Database. So that isn't such a challenge for us at the moment, because we've got each CCG in South West London updated on that, and we don't have a backlog. We've got all of the cases uploaded at the moment. In the paper that you've got, you do have the current changes on, so page 2 of 5 on page 74. You've got the things that we need to look at and change that will make us compliant with the new guidance. So the first one is what I said around having the local child death review partner, the change of responsibility, so that now being predominantly health with the support of the local authority. The next bit is what we said around the merger of the existing CDOP overview panel. So instead of having 6 in South West London, we now have 1 in South West London. And what that will mean is that each local area will have to develop a multi-agency child death review meeting. A lot of acronyms here, I'm sorry. And they will still do the initial rapid response, the investigation in the local area, and any learning in the local area will still take place. It's not going to take away any of that. And what that area review will do is then feed up to a South West London CDOP meeting that we will have around 10 times a year, probably every month we'll have one of those meetings. The other area that we do need to look at is having a key worker role. So there's an expectation that the experience of families could be better when these processes take place. If you can imagine, we've got investigations taking place and it's really difficult for the families to know who's responsible for what. So we'd have a key worker that would be someone who could signpost the parents to the appropriate person they may need to talk to, and that would be one point of contact for the family rather than having to talk to different people from different organisations. And then the last bit is the updating of the data, which isn't an issue for us at the moment in South West London. The ECDOP is up and running, however it is only funded until next April at the moment by Healthy London Partnership, and we will need to pick that up in the next couple of months as to what we will do following on from next April and whether that resource is still available from HLP or whether we need to look at sourcing that ourselves. So they're the changes that need to take place. What you've then got is some terms of reference for what will be the big CDOP, we've got a name of, which is where all representation from the 6 CCGs, 6 local borough areas will need to be at our meeting, and the terms of reference are here. We have got a independent chair already lined up to do this, the Director of Public Health, and the co-chair is the Director of Public Health, and we think we've probably got a facilitator to help with that as well. So we are set up for the deadline, which is September, and we do need to submit these terms of reference to NHS England and on the website by the end of June. There is an acknowledgement that this is work in progress, and we're not expected to have everything absolutely working across the 6 from the 1st of September. Well, it's the 30th of September, the deadline's the 29th of September, but there is an expectation that we've got the plan and that we know what we need to do. So I'm going to stop there and take questions. Without putting Dagmar on the spot, Dagmar's obviously very involved in the local arrangements for Merton as is, and they will change in some ways, but we do need to finalise the arrangements for Merton because Merton isn't linked to an acute hospital and most of the hospitals are taking on extra responsibility around this.
Sarah.
So firstly, I will start by saying thank you to the team because this has been quite a difficult discussion, and I have been at workshops with all of the local authorities and their leads across, trying to get to agreement on this, and we have got to an agreement. I think that's the right answer. It's the right thing to do, and thank you to the team for getting us to this point. I think that we needed to support it because actually we looked at many different geographical splits around South West London in order to get to the magic number of 60, and the only one that works is to do it across the whole of South West London. Otherwise you end up with somebody with less than 60 somewhere. It doesn't make any sense. Plus geographically we know South West London makes sense, so I think we should support it on those 2 points. On the issue of the HLP funding for the ECDOP, we fund HLP, so either it's coming out of our money or they've got some additional money from elsewhere. My view would be let's get agreement quite quickly for next year around the ECDOP because that would seem quite sensible, and I wouldn't want us to kind of trip into a position where we haven't got the ECDOP because we hadn't sorted out the funding. So I would suggest that we try to do that quite quickly. And I just wanted to ask the governing body to support this because I think this is absolutely the right thing to do. It's taken a lot of work to get us here, and this is about our accountability and my accountability actually is I have direct accountability as accountable officer around safeguarding and this in particular. So I think we should support this.
Dagmar.
Yeah, and if I can just lend my voice absolutely to the reforms as well, because as well-meaning as small-scale CDOP was, you cannot do the learning on the numbers, and there were some real wake-up calls where actually the press got hold of information patterns across London before local teams had cottoned on, because they put together on FOIs, the findings from various different CDOPs. So I think it is absolutely the right way to go, so that we really can do the learning.
Absolutely. It should, Sutton should be there. But it is included.
So,
all six.
so we're being asked to approve this. I mean, it sounds an incredibly sensible thing to do, and it sounds like it's going to improve the quality of our work on this. I haven't heard any objections to that. Are we happy as a board to approve this? Yeah. Okay. Good. So the next item in strategy and planning is moving forward together, which, Sarah, you're going to present for us. Have we got the...
So, apologies, because this went into, I think, part 2 by mistake. So it's in part 1. We've put copies on the... Oh, is that me making that noise? We've put copies on the... If I see, can you still hear me if I get it from over here? Yes. Okay. We've put copies on the chairs for the public. If you look at your part 2 papers, you have got the presentation in there, is my understanding, if you haven't got a hard copy. So I will just run this through for you. So we have actually on the front made a reference to moving forward together our draft case for change for a potential merger of our 6 CCGs. We have actually added that because we wanted to be clear that that is what moving forward together is. You know, it is not some kind of strange thing that we are doing. It is the merger discussion that we've had, and based on the intent of all 6 CCGs through the governing bodies to merge by April 2020. There is obviously a process to go through before we make a final decision on that, and we'll talk later about the timescales. But what this paper does, is it just sets out, this presentation sets out the case for change. I don't like this buzzing like this. Shall I use a different one?
Use my one.
Thank you. Because I don't know how much it's irritating everyone else, but it was irritating me. So we have identified there are a number of things going on, both nationally and locally, that mean that we need to change the way we work. So firstly, there's the development of primary care networks, which we talked about earlier. There's a real strengthening of our local health and care partnerships at borough level, and the development of the 6 local health and care plans, as we talked about, and we talked earlier about the strategy from the Health and Wellbeing Board. We are looking at different ways of commissioning and provider working collaboratively across the NHS, and that's talked about in the long-term plan. And we need to focus on people rather than organisations. And the expectation in the NHS long-term is also that we will make 20% reduction in our management costs within CCGs. So with all of those things, we know that we have to change what we're currently doing, and we believe that working together across South West London is a better option for us. So we've created, onto the next page, the Moving Forward Together programme. And it's led by the 6 GP clinical chairs across the 6 CCGs, along with my senior management team. We have a programme structure that includes 5 work streams, and I'm going to try and remember them all, but I'm sure I'll get one wrong. So there's governance, finance, HR, communications, and what was the last one? Functions. So that's the 5 clear work streams that I forgot one of. They will, as part of what we're doing and the approach we're taking, we want place, or borough, as we're now going to be referring to it, as the sort of primacy of what we're doing, and that we will build in a sort of bottom-up way. And it builds on the engagement that we've already undertaken on our local health and care plans, so that we can effectively engage with people as we move forwards. Just to kind of set out, I think I missed a bit, did I? No. that think we have a strong case for change. You'll see there's 6 areas. I'm not going to read it from that slide, but I'm going to pop through them individually. So first of all, what we are saying is this is evolution and not revolution. We already work really closely across South West London. Today we've already had a number of things that we've talked about where actually we are working across South West London, and it makes absolute sense for us to do so. We've also had some successful bids for things like children, young people, mental health, for specialist mental health teams for expectant mums, and we had a big chunk of money for South West London around digital, and particularly around sharing health and care records. We've also been doing things like improving some of the functions that we currently have by working very differently. So we always use communications and engagement as a really good example. So led centrally by Charlotte Gorn as our Director of Communications, but with local teams. It's professionalised, I think, communications across South West London, as has actually improved the level of service that people get locally at a more efficient price and in a more professional way. We had something like the Effective Commissioning Initiative, where we worked across South West London and ensured that actually there was not a postcode lottery in South West London, and that actually we deliver the best practice outcome-based initiatives to patients rather than something else. And I think that we've actually proved that nationally we're probably better at this. They call it EBI, I think, nationally, but we're better at this than anybody else, I think. I think we're the first or second best in the country. So on the next page, we talk about primary care networks. So we need to free up resource from our sort of back office administrative functions in order to support the front line. And one of the areas that we recognise that we'll need supporting going forwards is primary care and PCNs. So we want to look at developing PCNs, working with general practice, making sure that we can deliver a range of services at network level, and that will need to be part of our investment going forwards as we move this process forward. Which brings us on to the next section, which is section 3, which is about primary care, because we know our local GPs will be worried about anything that means we consolidate, that they are going to get the same level of support that they currently get. And we've said across South West London that we will maintain the current teams and the current level of support that we have, if not improve it, because what we would like to do is make sure we have the best support for primary care across South West London. So we'll probably enhance it rather than reduce it. So that's the way we're going to work, and that we've made a commitment to the LMCs and to local general practice. If we move on to 4, we think that by reducing the amount of sort of bureaucratic processes we have in the system, we can actually reduce the amount of administrative costs that we have associated with those. So actually by looking at some of the administration of the way in which we do the contracting and moving that forwards, we think that we can take some of the administrative part of that out. We also think that we can support NHS organisations to collaborate and learn by working across South West London. And although we do need to do a lot of things at borough level, we've also recognised the benefits of doing some things across borough, and actually the way in we're set up means that we have to do some things across South West London. We set in play the South West London Clinical Standards. That's another good example that was agreed by the Clinical Senate, and actually all of our acute providers are now trying to work to those clinical standards. So that's a very positive thing for South West London. So in the next bit, we're also talking about the costs associated with running 6 governing bodies. So I was working it out this morning that we currently have 6 governing bodies meeting 6 times a year in public, 6 times a year in private. That is 72 meetings a year, and on top of that, there are various committees associated with every single governing body, 6 sets of annual accounts, 6 sets of orders, 6 sets of assurance processes with the regulators, and the clinical and managerial time that we spend just on bureaucracy rather than doing things, we think we can reduce that and still retain the same level of oversight that we need to have. So we also think it's better for our staff because at the moment, if you're in a small CCG, it's a small team and there's not often as much opportunity around career progression or training, development that there might be in a bigger organisation. So by becoming one CCG, we think that we can support our staff better, retain our staff, but also get new staff into the NHS and work in a better way. And we've also committed to our staff to try and minimise redundancies, and that we believe that on the scale we can start to do that, particularly around natural wastage, making sure we don't have as many interims, and we can manage better across South West London. Finally, we wanted to talk about the place, which we're going to stop calling place, we're going to call it borough from now on. When we first started this process, we talked about place because we weren't sure locally whether people wanted to have cross-borough committees or how they wanted to set those up, so we talked about place. It's now very clear across South West London that there will be 6 borough-level committees, and on that basis I think we can start talking about them as boroughs. And what we want to do, and it says here, have at least 80% of care planned and delivered locally. Our intent is actually to delegate 100% if we can of the budget to local on the basis that we work together with some of the functions across South West London. So that there will be a level of ownership locally of what we do, but recognising that there are some things that make absolute sense for us to do together. And then finally, we would like to take control of our own future. This is coming, this is set out in the long-term plan. We know this is the direction. Every area of London is now doing this. They're doing this nationally. But we are now in a position where we are forefront in some of this. We've been able to influence some of the London-wide thinking and the national thinking about how you do delegation at borough level. We are in a position now where people are listening to what we are doing in South West London, and therefore we are able to influence others rather than being told this is what you're going to do, South West London. And I think that's a big bonus for us in South West London. So then I'm just going to take you through, so this is the next picture you will recognise. I hope it just puts the borough, the South West London system and the wider than South West and the neighbourhoods in context. This is the what we use all the time around our integrated care system for South West London. The following slide tells you that actually we're going through a process with each of the boroughs to say, how would you like to work for you locally? What kind of level of delegation would you like, and how would you like to set yourselves up? How will the financial architecture for this work? And we had a workshop, was it last week or the week before? And we brought together all of the systems across South West London. Actually, it was a really good workshop, a lot of learning going on across the piece. Very clear that everybody's interested in full delegation, and I think we can make that work for South West London. So we've had that 3-step process, and part of that 3-step process has included how people will work together, which is, so I'd like to put you to this slide, which it hasn't got a number on it, which is a good thing, but it looks like that, it's the orangey one, that says that there are different ways in which we could manage our budgets and our delegation at a local level. We could do what we're currently doing, which is collaborate together, so we can just all work together. We could align our budgets. So if on the right-hand side, you see that's one plan with 2 budgets. So we could all meet together. We could have one plan that we jointly work to, that we invest in, but we all retain responsibility for our own budgets and our own statutory responsibility. We could have joint budgets, which is one plan and one budget. So we could put all our money into one big pot. We could have one big plan, and we just all work to that. Or we could have a contractual arrangement with South West London, which nobody is ready to do. I think that's somewhere in the future. I think we should just look at the top 3. But you could have an integrated care provider at a local level that just has a contract with South West London. Nobody's yet in that position, but that is a possible future model. Most people in South West London at the moment, although they have some joint budgets already around things like the Better Care Fund, but most people are looking for the general as an aligned budget. So we have one plan, but we retain our statutory responsibility. So now I'm going to hand over to James to talk about the Merton.
So page 24 just talks about Merton and the Merton long-term context, because what we can't do is have solely a Merton context. We also have to work in partnership with other boroughs where we share some common providers. So for Merton and also for Wandsworth, we are proposing to take full delegation of the CCG commissioning budget to the borough level structures that we want to set up. We already have a combination of collaboration of aligned and joint budgets with the local authority, so we already have a number of joint budgets. We have integrated commissioning teams, for example, around children's services as well. So actually we already work, and the local authority commission learning disability services for us under a Section 75 arrangement as well. So there's quite a high level of collaboration already. For April 2020, we're not anticipating new joint budgets either with the local authority or with other bodies, but what we are anticipating is that rather than having a clinical commissioning group commissioning intentions and planning around process, we will have a process which is about year 2 of the local health and care plan, which will be led through Merton Health and Care together and will be a cross-agency process around delivering the local health and care plan. So will obviously involve both social care, children's and public health elements of the local authority, but will also involve our partners in acute, community mental health, primary and voluntary sector services as well. So really putting in place now the Merton Health and Care Together philosophy towards planning and delivery. But we know that as a borough, we have to work with other partners, and one of the most important partners that we have to work with is St George's. So we are 15% of St George's income, and they are our largest acute provider. What we have been discussing with colleagues at St George's and also borough partners in Wandsworth is how we work together around St George's in the context of delegation of the budget down to a borough level structure. And we believe that we need a partnership board with St George's, where both borough leadership teams will be represented, but can at a very simple level bring the relevant boroughs together along with the other commissioners, bearing in mind that St George's is 50% commissioned by NHS England for specialised services at the moment, to support St George's to have a cohesive overall strategy within the context of borough level planning and delegation. So it's about emphasising the primacy of borough as place, and that being the basis of the delegation, but also recognising that if each borough wants to do something radically different with its services and its links with St George's, then that will be really untenable for St George's as well. This builds on the fact, and I think it's important to emphasise that, of course, our transformation work with St George's already happens across Merton and Wandsworth. When we're doing work around emergency and planned care pathways, we do it jointly with Wandsworth and with St George's, because it simply is not tenable to have a separate Wandsworth plan for dermatology and a separate Merton plan for dermatology. There needs to be a plan for this service which is primarily focused on the district hospital catchments, the local people which are served by St George's. A further complexity for Merton is, of course, the fact that it has significant flows into 3 other acute providers as well. So one of the themes we were exploring at the place-based seminar last week was how and when Merton borough colleagues need to play into the Sutton Health and Care approach, particularly around reactive services and around the pathway around St Helier Hospital. And that's something where we're continuing to work with Sutton colleagues on making sure that we're involved in those discussions. And similarly, we still have significant flows into Kingston and Croydon, which needs to be taken into account. To support the work of Merton Health and Care Together, the CCG and Council are looking at how we contract for services. So we already hold a contract to which we're both signatories with Central London Community Healthcare, which covers many NHS community services, but also a number of public health services as well. From the CCG side, we're clear that we'd like to, when that contract it's time to move on with that contract, to look at moving forward in a more joined up way, and looking at where we should be contracting for a wider range of services on a more joined up basis. And we're having that conversation with a number of partners, including the local authority, just to see what the scope of that might potentially be. But there's going to be a lot more engagement about that yet, so there's not a huge amount to say on that. But it is, I think there's a real interest within Merton about trying to make sure that we embed really joined-up working arrangements in all of our contracts.
So finally, there is a timeline. As I said, we are in a process. We have not completed the process yet. We are currently just past the first purple blob. So we have had the place-based delegation seminar with partners, and we are currently working through the function structures and the actual structures of the staffing. We are working on the merger application and all of the bits and pieces that are attached to that, and then there will be a process of getting agreement from the membership and submitting an application, having gone through membership and the governing bodies. We have already started the engagement with membership, and I know that Andrew's had discussions where you've been out and you've had it in your usual meetings, and we've been talking about it across South West London, and we're talking to the LMCs as well. I have this week just had a look at a FAQ for general practice to go out to all members based on a recommendation from the LMCs that they had seen from South East London. So we have sort of South West Londonised that, and we hope to get that out by the end of this week. But we will keep that up to date, and if members of the governing body, GPs, others, hear anything from the membership that they think, oh, that's an interesting question, we need to answer that, please let us know, and we'll keep that FAQ updated to go out to the membership. If we're successful in our application post end of September, then we will start all of the formal process around staff consultation appointments and getting everything in place for 1st of April. We have said that we would try to do some shadow running. I'm not sure how possible that will be, going towards the 1st of April. We'll have to see where we get to if we get a long way along there. And I was going to pause.
Thank you. And you weren't seeking formal approval of this. This is really for information, isn't it? An opportunity for people to ask questions and discuss. Dagmar.
Thank you very much, Sarah. I wonder whether you can help me understand a little bit. There was an announcement recently that our South East London partners have turned into an ICS. And so if you help us to understand what that means in comparison to South West London, is there any learning and how the ICS process is linked to the merger of the CCGs? Because it has caused a bit of consternation.
So I honestly can't tell you what the difference is between South East London and South West London. I think we're in a very similar place. I think the difference is that South East London has now got the stamp that says it's an ICS. That is the difference as far as I can work out. Do remember that an ICS is a partnership. We haven't put ourselves forward to go into the pipeline, but we are in the process now. So through our programme board for the STP across South West London, we are completing a maturity matrix, which will tell us how close we are to being able to apply to be an ICS. I think that we need to agree together whether or not we wish to do that, and then we would just put forward the work that we are doing. And you've got to remember, an ICS is not a statutory organisation, so it is about how the partnership works and how we're progressing together. I think we've come along huge amounts in the last couple of years in South West London in that partnership and that collaborative working. I personally think we are ready to start to take that journey to get our stamp, but it will be up to the partners as part of the programme board to make that decision. But if you asked me personally, I would say there's not a huge amount of difference. I mean, we're doing the merger at the same time. We have a similar governance structure. There is not a great deal of difference in what we do. I mean, the intent is nationally that all STP areas will become ICSs by 2021. That's in the national NHS plan. And that will be what we were working towards.
So just for clarification, the merger application and process and becoming an ICS are separate.
It's totally separate.
Yeah.
And you can be an ICS and not merged, and you can be merged and not an ICS, or you could be both.
And I don't know enough about South East London, but my perception is we've maybe been a little bit stronger on how important we think the borough-based decision-making and delegation is. That certainly comes through more strongly in what I've seen.
Okay, I mean, that's a view. I think they do have a strong borough base as well, but I'm hoping that partners locally feel that we're doing this in the right way in South West London.
I may be inaccurate in this, but I think the fundamental difference is that for South West London, I think there has been greater engagement and it's been a more of a bottom-up approach, if you like, whereas my understanding is that there's been more of a top-down approach across South East London, saying you will rather than shall we. But that's my understanding. It may not be entirely accurate.
Thank you for that LMC perspective, Mark. James?
I think it's a really interesting point, isn't it? I mean, I think it's worth just revisiting what an ICS is in this context. So an ICS, integrated care system, in this current NHS context, what that means is a partnership of the health and care partners that are in a place working together in a different way, and it's really about the emphasis on the interests of the system and the system working together to support people who work, have needs across multiple boundaries and settings of care. Right, it's not an organisational construct and it has no legal status. So I think, in a sense, it is what we are all working towards, and I think that there is just there's a national process that basically draws a line at where you've reached a level of maturity in those relationships. But I think it's something that I've seen very much embedded in both. Actually, the spirit of it embedded in both our borough level and our South West London level conversations.
I suppose one concern that may have been voiced surreptitiously in various places is that this is opening up the NHS to privatisation further down the line, and I don't think that is the case, but nonetheless there are comments around that type of concern with ICSs.
Yeah, I mean, that's not what I see, and it's not the intent, definitely, from South West London. In fact, I think, us working more collaboratively with our providers means, that we could be sort of more NHS focused, actually, rather than less NHS focused. So I'm not sure that I would agree with that perception. Well, I don't agree with that perception. It's not that I'm not sure. I don't agree with that perception. Yes, I know it's out there, yeah.
One other quick follow-up. So thanks, Sarah. I think that was my understanding. And so it points to clarity in communication and terminology, because there's a lot of muddying out there, which isn't always helpful around what we want to achieve. So one other obvious question is, when the NHS is moving towards the maturity assessment and then labelling systems, either they are an ICS or not yet, what's the advantage? So what is the NHS granting an ICS that makes it attractive to strive to get that stamp?
So I'm not sure what it will be in the future. I can tell you what I'm told by existing ICS colleagues is that you have a bit more autonomy. So you have a little bit less of the top-down from the regulatory bodies, because you're a trusted system who can get on and deliver what needs to be delivered. And there has been money attached to it in the past. Whether or not there will be, I mean, it looks as if, based on the plan information that's come through, and we have additional papers that that aren't public, that says, and this is the templates you've got to fill in, and here's some of the money attached to it. So there is some additional funding that's coming down around transformation, but it is going to everyone. So I'm not sure whether or not you get the added benefit of being an ICS in the future, but if there is any added benefit, we would like to get it. I always find with these things, the earlier you go, the more benefits you get. So we're not in the first wave, so we may not get as many benefits as some of the others did. But that might be worth bearing in mind for the future when, the next new thing comes along.
Claire, I'll come on to you, but just on the issue, Marek, about kind of opening it up to private providers, we talked about an integrated care system at the Health and Wellbeing Board, and I think what we reflected on is we've been on the journey towards integrated care in Merton for some time, and what that means to us is collectively those organisations that currently exist, like the CCG and the local authority, taking collective responsibility for the health of the population and trying to get our providers of healthcare that we currently have working together in a more joined up way. Not any sense of opening up the market to someone else to come in and take responsibility for our population's health, or necessarily looking for new providers to come in to do that, which I think is where it's been a bit conflated, because obviously some of the models in the States around integrated care have been very much private sector driven. That's really not what we're describing here.
Thank you. I think that's absolutely right to make sure that is a clear distinction. As I said, this isn't my view. I don't think that there was any such direction of travel, but I think it is a perception that is out there, whether that's amongst colleagues or amongst the public. And I think this is why I raised it, so that it could actually be shot down.
Okay. Claire?
Thanks, Andrew. I mean, clearly there are some real benefits to merging. But one of the real successes that I've seen in CCGs has been, because of their size, the patient and public involvement has been really valuable and has really drilled down. How are we going to ensure that that continues and also has its benefits fed through into the South West London merged CCG?
So it's a really good question, and my understanding is it PPAs? I never remember what it's called, but the South West London group of patient public that come together, and I think they've been thinking about how you bring this together. So I have a personal view, which is that we will be doing some engagement at a South West London level, but it'll be much more of the PPAs type, as in leaders coming together from across South West London to say, are we doing everything we should? Are there things that we can work with you on? But actually the real engagement will be at local level. And I think the role of the South West London governing body will be to make sure that that is happening. So the South West London governing body will want assurance as part of anything that we're doing locally that that level of engagement is happening. Each of the places is looking at how they do that. So, I know the PPAs, one of the proposals was that you have a local engagement group across the borough. I think that looks like a very good model. I would hope that maybe that's something that we decide to take up, but I think it is worth us working that through over the next 6 months to make sure that we actually enhance what we're currently doing and do more, not less. So my question is, what do we need to do from you guys? What do we need to do more in order to make that really work? Because I think there's a real potential to do more.
Did you want to come back on that?
Yeah, so just to say, I think that we haven't done the bit of detail around it for the Merton structure. I've assumed that we will have some form of patient and public representation on our future borough-based governance arrangements, integrated borough-based governance arrangements. But I think that, so it will definitely be there, because just a reflection on the Merton Health and Care Together meeting that we had yesterday is that almost every item on our list of priorities is just completely impossible to take forward without much better co-production and involvement. So it will need to be a part of our arrangements, because if it isn't, then we won't actually move forwards, and that's kind of very well embedded into our plan now. So yes, we've noted the requirement, and we're yet to work through the detail.
Andrew. Thanks. It was just reflecting on yet another cycle of NHS restructuring is difficult on the people that work within those organisations as well, and I think it's welcome that we're trying to clarify things as soon as possible, because with 80% coming down to the borough-based level, it would be good to try and be able to offer those positions to people who want to keep, to maintain the quality that we've had as a CCG. And just one other point, place is always confusing. Borough is the level it's at, but my worry, if we're called Merton Borough, is that sounds very much like local authority. So whether we're Merton Health or just for that clarity.
I feel like I'm repeating myself, James. So we had this discussion in Wandsworth. I think what's really important is that it's, what do we call it at South West London? We might call it place, borough, whatever we do. I think it's, what do you want to call yourselves locally? So for Sutton, it's Sutton Health and Care. For Croydon, it's One Croydon. It's Kingston Coordinated Care. I can go through them all. And I think Merton Health and Care Together. Merton Health and Care together. So it might be that we just start referring to them by the right words, which is the words that you're using locally. I think it's what do we call the boroughs level thing when we're talking at South West London, because we're not going to go through the list. But apparently people don't like place. So, there's lots of issues, aren't there, around words that we use. So I'm sure we'll come up with something.
I'm personally going for unit of geography as being about as neutral as I can get. Just on the 80%, so the 80% is 80% of a minimum 80% of delegation. In fact, actually, we're all asking for full delegation. Even with full delegation, I don't think that it means that 80% of staff will continue to work in place-based teams. I think that we will be, actually we're not working on that basis. We're saying what functions do we need to have at local level and what functions are best discharged at South West London level. And even when functions are discharged at South West London level, then it doesn't mean that it's not actually in service of decisions being made at local level. So a really good example is our comms colleague, so Jen, who was just here, is part of a South West London team, but supports local discussion and decision making from being part of a South West London team, because we know that for communications, we get better strength in depth by having a single team, but within that, some people who are assigned to local place. So I think that it's worth just creating that distinction. So the level of delegation and where functions sit is not the same thing. And actually, I think it would be a shame to constrain ourselves and say that 80% of our teams need to remain at local level, because we might miss a lot of opportunities to do things more effectively where we don't have the scale to do them at local level.
Thank you. I wasn't suggesting that 80% of the team would be retained, but I think given what we want to provide at a borough-based level, I think we need to retain those quality members that we currently have that are providing the functions that we're serving. That was just my anxiety, that we maintain quality at the borough level, and it's just not seen as a natural progression that everything is at a South West London level.
Do you mean quality management?
Quality management, yeah.
People.
Quality people.
So you mean quality people, not the function quality?
We've got great people. Let's not lose them.
We will be holding on to many great people to work across Merton and Wandsworth.
So the intention is we will have local teams. This is not about us trying to suck everything up to a South West London level. There are some functions actually that we already do at South West London that we would continue to do at South West London, and there are some functions where actually it makes sense to work across South West London, and we are agreeing that together. So we will do that. That will, there will still be, significant number of people working in the local teams. Also, just because people work across South West London, they can still stay in their current base, they can still work with the teams, and that's the way we're trying to work across South West London now. So I talk about one South West London, 3 offices, and it will be 4 offices. That's the way we work. And you can park yourself in any office in South West London, and the IT works, and you can access your work, and you can move around, and I can assure you it works, and I'm sure my colleagues can assure you it works. So that's the way we work.
Okay. Right. Mohan.
I've just got a question on sort of, we're looking at work delegated down to the borough level, and we've been working as an LDU across 2 boroughs, and obviously there's another LDU with Kingston and Richmond, although we're in Merton. So I kind of want to know how that sort of fits into the play of things in terms of, are we still looking at it as a Merton perspective, or are we still looking at it as an LDU, or how does that all kind of, without trying to complicate things?
Sure. So I'm anticipating that we'll keep a Merton and Wandsworth team supporting work in both boroughs, and the reason is that actually, if you look at, although we've got a single management structure, then within that single management structure, we've got some teams who work across Merton and Wandsworth, particularly around acute redesign. And then we've got some teams that do actually, although they sit in the Merton and Wandsworth structure, do work solely with one borough. So below a certain level of seniority, our teams who work on mental health, on children's, on some of our placements, etc. at the moment, and to a certain extent our community services integration as well, are Merton or Wandsworth focused within an overall LDU structure. So I'm anticipating retaining that approach. And the reason for that is that it's still, the rationale for the LDU 2.5 years ago was to share some of the senior posts, and it actually still does make sense to share many of the more senior posts. So we'll continue to work in the same way. Quite how some of our internal management structures, like the clinical oversight group and the exec management team, work in the new arrangements is something that we just need to work through a little bit, because clearly there's going to be more of a focus on making joined up decisions with other partners in each borough. So whether we move to that rather than having some of those consolidated meetings is something that we just need to work through. There may be a bit of a transition period where we're sort of having to double run a little bit as we see how it works out.
So I'll take you back to the kind of principle of evolution, not revolution. We're not going to throw everything up in the air and start again. We are trying to support both the staff to have a transition where that's required, but actually to try and support the good work that's already happening to continue to happen. So we're not looking to change everything overnight. That's not the intent. There will be changes, and we will support staff through that, but it's not expected that we're suddenly going to split all the LDUs up. We're going to, we're not going to suck everyone up to South West London. That's just not going to happen. That's not the intent.
Okay, thank you. So that was for information. I think we had a very useful discussion. Let's then move on to the next item on the agenda, which is standing item 6.1, the finance report.
Thanks, Andrew. So just to note, this is the month 2 finance report. So as we had in previous years, there's limited data available to make any real judgments on it. So what we are reporting is to plan. You'll see on slide 2, so page 101 of the pack, some financial key indicators on there, which are basically showing that we're achieving everything year to date and forecast on target. There is one thing on there, and the cash drawdown, we've actually only achieved 1 month. So we had a problem in the first month where we had we received cash too late and we couldn't spend it in time. So we failed that target, but NHS England, due to our track record, have said that they were content with it and that there was nothing that we could do. But obviously we can't have too many more of those misses as we go forward now. Just to note though, there are some key risks that are likely to emerge. So as part of the month 2 process, we've tried to do a bit of horizon scanning in terms of the likely risks that we're going to see. We think that we can probably mitigate most of the risks that have come up. We'll obviously be taking that through the finance committees and then provide updates to the board accordingly. Just to quickly run through the risks as we see it. So because of our outer sector acute portfolio being mainly on PBR, there are still risks that we could overperform, but we believe we've set contract values at a reasonable level, or at a prudent level based on outturn plus growth. There are RTT issues around St George's in terms of improvements actually in their plan. That is in the plan, but obviously if they exceed that, that could put further pressure around that. The rest, most of the contract is on a block, but that's one element that is outside of the block. We've got some small issues around year end in terms of the accruals being enough to cover those pressures. We don't think it's a major issue, but there are, particularly with the Mental Health Trust negotiations ongoing, so I'll bring back to a later board the assessment on year end. We're doing a review of learning disability placements with with London Borough of Merton. This could reveal a pressure, but we're trying to align that with continuing healthcare. And with that, the continuing healthcare legacy issues are still causing a bit of an issue. We think we're near the end of that, but there are things that are still creeping up. So I think at this point in time, it's prudent for me to flag it that it could still remain a risk. There is the Babylon GP at hand issue that NHS England have notified CCGs of a potential top slice to the allocation. In theory, if all of it is perfect, the allocation is equal to the healthcare consumed by those patients. but we're not quite sure whether the analysis that the allocation has been based on has been as robust as looking at the previous year's data. So at the moment, we've flagged it as an unmitigated risk in our reports back to NHS England on the basis that if it was a pressure, then we wouldn't be able to cover it, but we think there's still some further work to do it. I think just to note, though, that the allocation that we're being told actually could be more than the allocation that's been notified to us. The value for Merton is around about 200,000, I believe. So it's not an insignificant amount, but it's not the largest amount either. And then around delegated primary care, there's the primary care network DES. So if everything was to happen exactly as the guidance that has been given to us, then that potentially puts some pressure around the primary care budgets. But again, we usually find ways of mitigating primary care pressures in year as well. So just in terms of the mitigations we've got in place, there is some flexibility around the mental health investments. We've now agreed a risk share with London Borough of Merton around a high cost placement. And we will also release any of the contingency and any small reserves that we've got in place. So just ask the governing body to note the early time of the year, but the forecast is still on plan and the risks that I've outlined in the report.
Thank you very much, Neil. Any questions, Tim?
Yeah, it's just about the ongoing use of new technology like GP at hand, and in the sort of litigious world that we live in, and this sort of the extra probably nervousness of clinicians using something like a video consultation versus a more traditional face-to-face consultation, of when you would then employ the use of other services like A&E in particular, when you would refer on, I think is something to watch, because I think it's debatable about the onward percentages of using other services and therefore the other bills that get employed by some of the new technologies. But it's so new that we don't know quite what impact it's had, but I think we do need to be mindful of it. And certainly if I was a clinician, which many of our clinicians do actually work both sides of the fence, do more traditional face-to-face, and then this video consulting is the risk you take when you are a clinician making decisions, and how those bars or thresholds of referral might be lower with just a video image opposed to all the other signs we pick up when you're seeing face-to-face. Just worth keeping a very close eye on.
Yeah, I mean, absolutely. I think technology, I mean, I'm looking at it literally from a funding formula point of view. It's, it's clearly the way the system's set up at the moment isn't, if it evolves in the way that we're seeing, it's going to need to change radically. And I know there's a consultation out there looking at that at the moment, but I'm not too sure it's quite where it needs to be for certainly for this financial year. It's not going to be soon enough.
Anything else? No, so we're noting that at this stage. Thank you, Neil. Let's go on to the performance report. John.
Thank you, Andrew. The overall report I'll take as read, but I'll just talk to 4 or 5 areas to highlight some pertinent points. Beginning on page 114, I just wanted to highlight first of all the reporting error that occurred for the month of March with the Merton IAP data. So as we know, the performance in the latter part of the final part of the ad action contract did improve somewhat, but there was an error in reporting March. In essence, what the provider did was erroneously just report those patients who entered the service in the month, but also exited the service having been treated in the month, which is a very small number, just 35 out of the overall 251 who entered in the month. They should have reported the full number, the 251. They reported that subset. We have alerted relevant colleagues at NHS England to this error, but it was an unfortunate mistake as the service was transitioning from the legacy provider to South West London St George's. So just wanted to highlight that to the board. We weren't cited on it, and we weren't cited on it because we see the pre-upload template that is shared with us by whoever our provider would share that with us, and that did contain the correct number. We validate that with our weekly data, and that showed us the correct number. We didn't then see see the number they submitted on the NHS digital website where they made that interpretation error of the guidance. So the numbers who accessed service were 251, but the number that were reported was just the 35. So we continue to speak to NHS England about having that corrected retrospectively. I just wanted to raise that to the governing body. In terms of wider issues then, so we continue to focus on those areas where delivery across this year will be challenging. So the physical health checks for patients on the serious mental illness register and health checks for patients with learning disability, and also personal health budgets. Merton is at the moment tracking against its plan, but has significant steps to make across the course of the year. So we continue to work closely with commissioning colleagues and primary care colleagues who lead with us on those various areas. We're also focusing in terms of St George's on the migration, data migration at the Queen Mary Hospital site from the legacy patient administration system over to the Cerner system. We did a huge amount of work back at the beginning of the year with the Tooting site, and this is now the final part of their re-reporting. So they commenced reporting from January with the Tooting site. The Queen Mary Hospital site remained non-reporting, and once this migration happens, which is scheduled for September or October this year, the RTT 18-week pathways that take place at that site will be reported, and we'll have a complete picture of waiting times across all of St George's. At the moment, we see the majority of it, but not all of it. IAPT in its new provider isn't achieving the access target it needs to. The mobilisation was very well planned, but I think there's been various things that have impeded full access numbers being delivered, particularly staffing and recruitment. There is a formal escalation meeting a week on Friday where we'll be speaking to the leadership team at South West London St George's about the action plan that they shared with us a few days ago and the recruitment plan that crucially underpins that recovery plan. And there's a whole host of actions in there about communications, both to primary care colleagues and also to the wider general public, about how we get this service now back on track. I think we see the success that this same provider has in other boroughs in London, very strong delivery in other areas. It's ostensibly the same team, and I think we just want to get these initial mobilisation problems ironed out as soon as possible. So we'll have some very detailed discussion a week on Friday to do that. I think finally, although happy to take questions on other parts of the plan, we are working closely with St George's about cancer performance. It was strong performance across 18-19. There have been some issues with the April position around capacity for 2-week rural referrals, and also some particular issues around gynecology and upper-lower GI related to endoscopy capacity, related to some administrative processes. Again, there's a recovery plan that the Trust have put together, which we've in the process of reviewing. Cancer performance meeting is happening, was happening now at Wimbledon, the monthly System Leadership Forum, where that action plan is being reviewed. And I think we're confident that the Trust has put a huge amount of resource into resolving this problem. They have had strong performance across 10 out of the 12 months of last year, and in many of the waiting time standards achieved it on aggregate for the year. But again, it's another area where we're focusing to make sure that performance in that critical area remains above plan. But I'll pause there and happy to answer questions across the wider report.
Tim.
Yeah, thanks, John. Just the IAPT, and I think probably looking around the table, I think it's just Claire and I who probably go back the full 7 years of Quality Committee talking about IAPT. We're now on to our third provider. It's a little disappointing in the first month or two hearing things like recovery plan already being bandied around. We sat on Ad Action for quite a long time, didn't we? Sort of a couple of years really where we worked quite closely with them trying to resolve the ongoing issues to try and get a service. But looking back at Dagmar's strategy, of which one of the live well is mental health, depression, anxiety, which is a massive burden and causes a huge number of lost days of work and family functions, etc. What is our confidence that we are going to get an IAP service that can meet today's demands?
I think my confidence is high. I think I look at the delivery they achieve in Sutton, the delivery they achieve in Wandsworth using the same model. I think in the recent procurement that came across very strongly. I think the problem in the last couple of months has been one of recruitment and to some degree inheriting some issues during the transition. So, you always expect there to be some period of time when delivery will be somewhat impeded by a mobilisation. Possibly the modelling of the access rate during that period was over-ambitious, but I think fundamentally it's one of recruitment and not being able to get enough people either on a permanent basis or an interim basis, and I think that will be absolutely the critical focus when we talk to them next week about what confidence they've got in getting the right staff in more quickly.
Go on, James.
I think there's a couple of things for me on this. So it is important to first understand the quality of their recovery plan last week. I chaired the recovery meetings in Wandsworth 2 years ago, immediately after they've mobilised the service. I'm disappointed to be chairing recovery meetings shortly after they've mobilised the service, but what I would say about Wandsworth is that we had similarly poor performance in the first couple of months, and it did recover very quickly, so we know that they've got the wherewithal to do it. I'll be expecting to understand how they are managing their staffing on a South West London basis to provide, because they're now the provider for 3 boroughs, so actually, a staffing problem that starts in Merton is unlikely to be limited to Merton, so I think it's a wider issue. There's one of the things that we will be discussing with them, which I know is a key concern for GPs at the moment, is the route of access through the SPA, and about the function of the SPA. And one of the things that has changed over the transition has been we've moved away from direct access to online CBT to access through the SPA. I think certainly that has introduced another process step, and that's impacted the numbers entering treatment. I think I want to understand whether it is in the short term the right thing to do, given how well received some of the online offers were immediately before this. I think one thing that is different this time, which I'd share John's confidence, but just in terms of things that we are doing differently, is we've involved our South West London performance colleagues from the outset this time, and my colleague Jonathan Bates will be joining the discussion with South West London and St George's next time, because I think, just going back to the discussion about moving forward together, IAPT is one of the areas that we've debated long and hard how and at what level we should commission it, and I think we know that while it needs to link into local systems, so there needs to be a local element, actually when there are these performance issues, particularly in relation to larger providers, our South West London colleagues can help us to address those issues and to put a shoulder behind the effort to get them moving as well. So I think that early input this time is going to be very welcome.
Let me just pick up 2 things there. So one is you talked about the low numbers entering treatment, but when I was looking at the data on page 10 of the report, what was quite striking to me was the total number of referrals dropped quite significantly in April. Anecdotally, I think when you change providers, GPs lose some, perhaps, they're not confident about, particularly when you hear there's longer waits, confident about referring people in. And I think what you're not capturing here is the number of patients who are perhaps going to other places like Wimbledon Guild or other options. So once those numbers do pick back up, the gap between those entering treatment and total number of referrals will look more significant. And I guess my exhortation would be to be very quick to switch back on the other kind of capacity in terms of IESO and Big White Wall if we think we're not going to get there quickly enough. I might be worth us jumping quickly into that.
So those modalities are still in the supply chain. IESO and Silvercloud actually this time are in the supply chain. Big White Wall was a little bit more challenging, but IESO was very successful pre-transition. The question is about the route in. So there is a little bit more confidence with the Merton uplift model in terms of that initial triage and then the direction into the right modality. I think that particularly where people are seeking to access one-to-one face-to-face CBT, and we know that we have a structural workforce issue with that right the way across the system. It's not just a Merton issue. My question, and one that we'll be exploring next week, is why not online first and while you wait? So could we have people entering treatment with IESO while they're waiting for the modalities? Now, there may be some, I haven't actually had a chance to discuss this with clinical colleagues, and there may be some clinical reasons that we don't want to break the integrity of the model, but I think it is the kind of question that we, as you say, we need to get onto a little bit, very quickly this time.
So Andrew, our clinical lead for mental health.
Yeah, I think the frustration is shared across the board with how things have gone, but I do share John's confidence as well. I think the overall system, once it's up and running, will be a better offering for residents of Merton. There's been a large investment put into the service by the CCG, and it's not necessarily about money, it is about people at the moment, which is a challenge. I think we need to share that with our primary care colleagues, the process that's happening now. We've got the trajectory, how things will change. I think we also need to highlight a lot of the other positives are there. We're focusing on IAPT one-to-one face-to-face CBT. As James just said, there's no reason, and we mentioned it this morning in a meeting with the Trust, why we couldn't switch IESA on in our mind straight away so people could access that. The wellbeing and the primary care recovery service is also a large part of the Merton uplift. The wellbeing seminars and workshops have all started, which people can self-refer to, and a lot of positive feedback from there. And practices hopefully soon will have primary care recovery staff within their surgery also, which is an additional resource for practices. So I just think we need to communicate these issues with our colleagues. But I do feel confident that we've invested enough resource into it that we will get to where we want to be. But it's frustrating.
Yeah, I think the communication might be helpful because I'm not sure all our GPs are fully sighted on the full range of the offer. Marek, did you want to come in?
Yes, thank you. So, I mean, James and Katie will be familiar with the issues that I raised yesterday at Merton Health and Care Together, which very much reflected the issues that are being raised with Merton Uplift. And John's also already written to me and explained about the escalation process that's taking place and so on. I suppose really the most important for me at the moment aspect is where my colleagues and I, when facing a patient, what information we're actually able to give the patient about the service that is there, what the waiting times are, how to hold their hand, so to speak, if there's a prolonged period of time before triage, even conversations are taking place. I think you were right, Andrew, to state that perhaps there's a lack of knowledge and amongst colleagues about what the offering currently is, how to access it in its various forms, and also what to tell the patients about the weights. But from the CCG point of view, I think the fundamental here is reflecting what Tim was saying earlier. It's the reputational aspect of this. This has been an ongoing problem for a number of years. I felt that this is going to be broken, that actually we'd get there with this current re-procurement. It felt like that at the end of, well, the previous financial year. So it's sort of not gotten off to the start that I'd have wanted it to. And I think this is potentially, though, you may have a good news story a few months down the line, being able to say, look, this is really working. But GPs need to be fully informed so that they can keep their patients fully informed as well.
Dagmar.
Yeah, I just wanted to reiterate in a way the importance of communication because we cannot take it for granted that it has filtered through. And we alluded to in Merton Health and Care Together yesterday when we discussed one of the priorities is healthy workplace. I mentioned that in the health and wellbeing strategy as well. And actually, we have got big workforces and we've got the low-level mental health issues that this service wants to tackle. A lot of our staff is local. So making that service a local service for our workforce is also a really important issue that we haven't really used properly and marketed properly.
Mohan?
Yeah, I just wanted to add, just hearing all the comments, and certainly if this is a recurring theme and something which has gone through cycles before, I'm not sure we're going to suddenly come up with a silver bullet to try and sort it and rectify it. I'm confident that we'll get it to a level which is can provide for Merton, but we should really push other resources. We should push online. Social prescribing is going to get big now. We're getting them in all the practices, community groups, health champions. I think there might be other resources we can look at which is actually more sustainable rather than going, we haven't got enough recruitment of these particular workforce to deliver that particular intervention. So I think there might be some other things we need to kind of push out rather than, sorry, we haven't got enough staff at the moment. Just wait a few months. So, yeah.
Just to respond very briefly, I mean, I think you're absolutely right about the creative thinking about how do we bridge this gap at the moment. And I think certainly we will do that in the escalation meeting. We saw not using that approach, the Wandsworth position significantly improved 2 years ago when they were in a similar position, but certainly to be a catalyst to that, I think in this situation we need to look at that as well.
Okay. Good. Thank you for that, John. I think that was a really helpful discussion as well. So I'll move on from the performance report. We've just then got the summarised minutes from these three committees, which is for information. Was there anything anyone wanted to raise from those? Julie?
Just to say, in the Integrated Governance Committee summary minutes, we did sign off the Merton Safeguarding Partnership Agreement at the IGQC, and I just wanted that note in for governing body that we have done that. Well, Sarah signed it off, and that's now been submitted to the Department for Education by the local authority.
Thank you. Okay, so that's 7.1, reports from committees. Now we've got an opportunity for a member of the public to raise any questions.
Thank you very much. First of all, I would like to make a remark. You were talking earlier about ICSs. And you may or may not regard it as a problem. You've obviously heard that some people do. I would say that most NHS campaigners across the country regard these as a very dangerous thing, regard them as a stepping stone to ACOs and HMOs, which are regarded by health campaigners very much as a process towards not just privatisation, but US-style privatisation, and that's how it's regarded by people who take a keen interest nationally. A question about improving healthcare together, actually. You have submitted an outline business case to the Clinical Senate, and their response has been published. Can I ask why the business case that you submitted to them has not been published, as far as I know, given that you claim to have carried out extensive engagements? I don't understand how you can claim to have done that when you haven't published your report.
The question is the draft pre-consultation business case that went to the Clinical Senate.
So the draft pre-consultation business case is not yet publishable because we haven't got, I mean, it's changed already, but we haven't got the sign-off yet of the regulators around the finances and all of those things. What we have done, I think, is published all of the information that we have given to them. So things like the IIA, which is now in the public domain, and some of the reports that we've had on travel analysis and so on. So most of the stuff that goes along that, it will be published when we are in a position to publish it, but at the moment we haven't, it is just draft. And the report from the Senate is based on that draft PCBC, pre-consultation business case. It isn't an outline business case. We're a long way from an outline business case. That would come post-consultation. You know, there's a huge amount of work still to be done before we even get into that situation.
I mean, I hear what you say, but it seems to me very odd that you can have an engagement. When the Trust had a similar engagement, what they made public was a draft business case, and the public were able to look at it and respond to it during the Trust engagement period.
As soon as we go into a formal consultation period, we will make sure we will make sure that everything is available. I think we've been very open with all of the information that we put into the public domain, including all of the clinical models, all of our working documents. There's a huge amount of information on the IHT website which you can access, and as soon as we can make public information, we are doing that.
The Trust put out, in a draft form, numbers and figures about beds, about population sizes, about who the various proposed acute sites were going to cover. You have not given the public any of that sort of detail, and yet you've published the Senate's response to your document. It seems very odd that you've published a response without publishing the document that's prompted that response.
So I do think we have published some information on beds and the clinical model. If they're in catchments, I think that information is out there. If there's any specific questions that you've got, if you let us know, I'm sure we can respond to those.
I don't know what questions I've got until I and other people have seen the document you've submitted. Can you explain to me why you've published a response and not the document that it's a response to? How can we as the public understand the response if we haven't seen what it's responding to? It seems like a very odd way of going about business, especially when you claim to have carried out extensive engagements about very little information.
So I think maybe the key question here, Sarah, is why did we, what was the purpose of us publishing the Clinical Senate recommendations? I'm assuming that was to show that we've taken work through the Clinical Senate, are looking at their recommendations, and we'll be taking that on board as we refine the pre-consultation business case.
Yes, so the Clinical Senate is looking at the clinical model, which we have published, and it is giving us advice on what they think from the South and London perspective about whether or not they think the clinical model is fit for purpose, which they have said they do think that the clinical model. They've raised 94 questions, which we are responding to. Yeah, I think they are very good questions, and we are responding to all of those questions, and I believe that we have also published a response to those as well. As soon as we can...
Can I ask you where you published those?
With the Clinical Senate, we've done a response to the Clinical Senate as well.
Is that a public document?
Yes, it's published at the same... I believe that we've published the Clinical Senate and our response to the Clinical Senate.
Where would I find that?
On the website, with the Clinical Senate report.
So you're saying that there's a response?
So if it's not on there, if our response to that is not on there, I'll go back and check and make sure that it is. I think we did a response to the 94 recommendations. But if it's not on there, I can find that for you, because we were publishing that.
And I'd like to see it, but I really would, and I'm saying this on behalf of Article 2, we really would like to see the document that is responding to. It's like public saying, this is the answer, guess what the question was.
So we're not...
I really think it's remiss that you haven't published the document. They found 94 problems with your proposals. 94 is quite a lot. And I think it's your duty to publish what you've shown them and tell us what they're responding to.
So I will make sure that our response to that is on there. They've made 94 recommendations, and we have listened to those recommendations, and we're already working actually on a lot of them already. So I'm sure that we can give you the information around our response to the Clinical Senate. I will check whether that is on the website.
So just to clarify, so I think I'm just on the website now, and just to clarify, what we've published is a summary of the recommendations, which also sets out the specific working groups we set to work through the detail, because of course we wouldn't have worked through the detail.
No, but
it's our approach that we have set out.
What I've seen is a two-sided document, and that's a very minimal response to a 90-odd page critique.
It's not our full response, because we won't need to do that until we actually get into a full process, which we are not in at the moment. This is working documentation that we have. We are trying to be as open and honest with the public in publishing working documentation. I mean, what we could do is we could keep all of this secret until we actually go out to public consultation. That's not... Sorry, let me finish. Can you let me finish? Yeah, so what we could do is we could just keep that until we go out to public consultation. That's not been our approach. We've been as open and honest as we can. We've published documents as soon as they've been available, and that is what we are trying to do now. As soon as we come to consultation, we will publish absolutely everything. We do have to go through formal processes with our regulators, and we will complete those first before we publish some of the documentation, because some of the information in that may change on that basis. So we're not going to publish things that we then have to amend. So that's where we are in the process. We're not actually in a formal process at the moment, and as soon as we get into one, we will make sure absolutely everything is available to the public. I think that we've been very open with the documentation that we have shared so far, and we will continue to work in that way.
Can I just say that the Trust saw fit when they carried out their engagement, and they said it was going to lead to the consultation. They published draft proposals, and the public could see them and begin to understand it. Because the public are at a disadvantage. We don't know where your thinking is. We are playing catch up all the time. Day one of consultation, you will be presumably asking people for responses. Day one of a consultation consultation, most members of the public will have had no opportunity to analyse what you're proposing. I think it behoves you to give people enough time to understand your proposals, and I suggest that that means that you should publish your draft recommendations. The public are not au fait with your terminology or plans, but they're quite clever enough to understand this is a draft and not necessarily the final document. I suggest you owe it to the public in the name of transparency to publish your draft plans, which you have shown us the responses to. Don't show us the answers, please show us the original document.
So let me come in here. I think a few points. Firstly, the key thing that the Senate was asked to look at was the clinical model rather than the full draft PCBC. They had that for information. So really the key point around the clinical Senate recommendations is how satisfied were they with the clinical model that's being proposed. I think comparing what we're doing with the trust process, you can't really compare it because it was a very different process, and we are in a prescribed process that we follow now, and now that the CCGs have taken over, looking at the Improving Healthcare Together issue. In terms of day one of consultation, the whole point of consultation is it's a long process so that people have time to absorb the information that we publish at the start, respond to it, and it will be a dialogue with the public, not a, here you go, what do you think, give us your answer on day one consultation. That's really not what we're describing. I think what we need to do now is bring this to a close, because we could have a long dialogue around IHT. That's not the purpose of this meeting, but I'm sure we'll have plenty of other opportunities to discuss it going forward. Thank you, Sandra. So I'm going to bring us to a close. We haven't got any other business. The date of the next meeting is Wednesday, 4th of September, and that's back here at the Chaucer Centre.